Sometimes you have to wipe it first.
Okay, explain what you mean by that.
Clean catch.
You want a sterile sample.
Okay,
So if you just go right off the bat, you might have some stuff there that isn't really there, but it's there.
some contaminants, right? That we don't want to see.
That's the word.
Go through.
You don't want to guess the first bit, you want to let it go a little bit and then guess midstream.
Yeah, there you go.
Clean catch.
What else? What are some casts? Okay, what about those casts?
Waxy cast.
Yeah, you remember that waxy cast, right? Okay, we're gonna go into a little bit more casts. What else can you find? So when we do the dipstick, what are we testing for? Yeah. Okay. So y'all pretty much read it this afternoon, but you gotta read the slides. Okay. So here's our clinical introduction scenario. A 24-year-old presents with dysuria, urgency, and suprapubic discomfort. On physical exam, there is a mild suprapubic tenderness. A urinalysis chem strip shows positive leukocyte esterase. What is that? Good. Nitrite. What's that? Very good. And trace blood. The provider initiates empiric antibiotics for a lower UTI, which is what?
Urinary tract infection.
Infections, while awaiting culture confirmation. Okay, so since we're going to be talking about urine, we got to talk a little about renal function. But I know you all got a lot of this in A&P. Just know that the nephron is a functional unit of the kidneys. It filters blood, it concentrates urine, it excretes and secretes waste and reabsorbs nutrients. It's clinically significant for us because this is what we're going to be talking about for the next 2 lectures. So some renal function mechanisms. You have your biological role, your renal filtration, and this filters water, salts, and glucose, and then it also retains those larger particles like proteins and blood cells. For renal concentration, that's regulated by the ADH. You have the vasopressin ADH control water reabsorption, and high ADH levels reduce urine volume while low levels increase it. So why is it significant to you? Because if you see overhydration, this may lead to a diluted urine sample. The biological role of the renal or the excretion and secretion functions of the renal function. We will test for creatine and hydrogen ions, and we'll talk a little bit more about that later on in these slides. Yeah, and that's good for this slide here. So I really like this slide, y'all. I like it a lot because you all are going to be seeing a lot of these terms again, okay? So polyuria. Polyuria is an increased urine output. You see this in patients that have chronic polyuria, and this has helped to rule out diabetes, mellitus, and diuretic use. The next term is oliguria, which is a decrease in urine output. It's less than 500 milliliters per day. You'll usually see those in those who have vomiting, diarrhea, or burns. You would need to replenish their fluids after seeing this, especially when people have severe dehydration. You have anuria, which is no urine or without urine, less than 100 milliliters per day. And usually you'll see this in type of mechanical obstructions or kidney injuries. Anytime you have patients that are not producing any urine, you want to include any imaging studies, and we want to test their BUN and creatinine levels as well. Then you have dysuria, which is pain or difficult in urinating. You'll see this in UTIs. So I wanted to say you're going to see UTIs a whole lot in here, okay? So UTIs, you'll see this inflammation. You'll see this in vaginitis. Glycosuria, which is sugar in the urine. You'll see this in type 1 with type 1 and type 2 diabetes. Proteinuria, which is an increase of protein in the urine. Bacteriuria, which is also seen in what is the term that I said we're going to talk about a lot? UTIs, okay? And hemoglobinuria, where you see a lot of hemoglobin in the urine, okay? And we're going to talk more about hemoglobinuria later on, block 4, when we talk about transfusion reactions and things like that. Okay, so types of urine specimen collection. So you already said some, right? You already talked about that clean catch, right? And what that specifically means is, if you've ever had to submit urine to lab, you'll see those set of instructions in the restroom. So you want to go ahead and use that wipe those cells off first. Do a little have a little bit of urine go into the commode, and then you wanna go ahead and collect that specimen. And the reason for that is because you don't wanna get those skin cells into that urine. That could be possible contamination, and we wouldn't be able to send it to micro for culture studies, okay? So, again, another very good slide that you all need to know. So random, no special preparation, they just go ahead and pee in a cup. A lot of times you'll see this in emergencies when they can't get that midstream. Then you have first morning. We see that a lot in pregnancy testing, and a lot of times because those high level of concentrations you'll see a lot in the morning. We talked about the midstream clean catch. That is our preferred for routine screenings. Okay. Another one I want to highlight on this slide is that GTT. You'll see that a lot in a lot of your pregnant women as well. And 24-hour is a quantitative measure of chemical substance excreted over a 24-hour period, okay? So when a 24-hour collection is collected, we're not necessarily using that dipstick. We're actually taking it back, running additional studies, more quantitative studies. So make sure you know that one, that 24-hour, okay? All right, so we're gonna talk about 3 types of urinalysis. We have the physical exam, what it looks like, chemical, which is that dipstick, and then microscopic examinations. All right, so physical examinations of urine, this is not necessarily like a diagnostic tool, but it will help you in trying to figure out what's going on with your patient, okay? So if you see pale yellow, you're thinking well hydrated, you're doing okay. You're seeing something dark, yellow, red, or brown, you're thinking, okay, something else is going on with my patient, okay? So we'll break down a little bit of some abnormal colors, all right? So red urine also can be seen in menstruating women, so you have to take that into consideration. It may not necessarily be abnormal, but if this person is not a menstruating woman, right, it could indicate hematuria, which is the presence of intact red blood cells in the urine. This could indicate possible kidney or urinary tract issues. Then you have hemoglobinuria, which the abnormal color would be red or brown. So if it's cloudy red, those red blood cells can be present. There also could be white blood cells as well. If it's clear red urine, then that's hemoglobinuria or myoglobinuria, okay? Dark yellow urine, usually influenced by the hydration levels. A lot of times they say if your urine's dark, you need to drink more water, right? This is what we all hear in the military. But you all are PAs, so we got to dig a little deeper into what dark urine looks like. So most of it is non-pathological, right? This indicates dehydration, maybe some intense exercise or heat exposure. But pathological causes could be from bile pigments, from the conjugated bilirubin, could indicate some type of liver or biliary disease, okay? Orange urine you'll usually see in severe dehydration or from jaundice or rhabdomyolysis. And a lot of times, not only will you see this in UTIs, but you'll see this in bladder infections and some certain types of antibiotics as well will produce this orange-colored urine. Brown urine is pathologic, okay? So this is considered, there's abnormal substance or there's degradation products in the urine. The most common or the most clinically significant that I want you all to know is that rhabdomyolysis. That's that cola color, and this is due to the release of myoglobin from the muscle breakdown, all right? So very dark, very thick urine, sorry. Blue urine. I've never personally seen blue urine, so I can't give you any real-world experience, but based off of this slide, this is influenced by dietary factors, infections, genetic disorders, and medications, okay? Pseudomonas infection is very rare, but she does produce blue urine. That blue diaper syndrome, also known as endoconuria, is a rare inherited disease caused by tryptophan breakdown by a GI bacteria, okay? And these lower levels of tryptophan in the blood and high levels of indican in the urine produces this bluish urine, okay? And then there's also the drug-induced causes. I will not test you on the drugs, but you all do need to know what types of drugs, though, because you will So what I want you to get off of this, for the sake of CLIN LAB, when I talk about blue urine, I'm gonna be referring to that blue diaper syndrome and what that's associated with, okay? So clarity is the appearance of the urine. Normal urine is clear. Usually doesn't have anything in it, and there's no non-pathological haziness. Can be mucus, seminal fluid, or crystals. Sometimes you'll have some squamous epithelial cells. And then you have pathological haziness, which is lipids, bacteria, red blood cells, white blood cells, and renal epithelial cells, which we'll go a little bit more into. Now, odor, it'll help, but it's not something you will ever see on a report. It's not even anything that we're supposed to report. But fresh urine usually gives you that pungent smell. It's not reported at all, and that stale urine usually has that ammonia smell. So we'll usually know if your patient has submitted urine and you didn't get it to us in time and it has like that ammonia smell, we know it's been sitting out for a little bit. And more than likely, if we don't get it within the required time, we will reject that specimen, okay? All right, so here's some more unusual urine odors. This is a very good slide. It's a nice slide, but like I said, this is not any of these that smell. Like these smells, it's not anything we'll ever report to you, okay? So these most common is sweet and fruity, ketoacidosis, is mousy, musty urine, is PKU, associated with PKU, and these sulfur byproducts will also produce the unusual urine odors, okay? Let's see what else. We got rotting fish smell associated with trimethylminuria, maple syrup, usually associated with maple syrup urine disease, sweaty feet. Yeah, this is all, yeah, like I said, sweaty feet, rotten eggs. We don't use these terms, okay, but it's just something to associate, okay? So, yeah, we don't start to the next one because that's really not anything we'll ever report to you. All right, but this we will report to you all right? Chemical analysis of urine, all right? You will see it when we present our panels. It will look like this. You will have and you've seen my test, right? So I will have the actual test itself. We will have the value, and then the normal values will be off to the right, okay? So just know that Chem strip or dipstick, those are interchangeable. Any questions so far? I've been going through these slides and I don't want to, okay. All right, so a urine analysis panel without microscopic. So that's pretty much, we have the sample with us, we dip the urine in there, we let it sit for 2 minutes, and then we read each one of the paths, okay? So please get to know this side, okay? This is what you will need, all right, for that test. So glucose, our normal values are gonna be negative to trace. The glucose is reabsorbed in the blood. Blood glucose are levels, and they should not be in the urine, all right? So normal urine should not have glucose in it. Bilirubin in normal urine should be negative. These are waste products from hemoglobin breakdown in the liver. Ketose is a breakdown of fat. It indicates excessive fat metabolism. Specific gravity is a measure of urine concentrate. Then you have blood, which we have talked about. Those RBCs that are not filtered through the glomerulus will be present if there's some abnormalities going on. You have your pH between 5 to 8. Protein negative to trace. Urobilinogen formed from bilirubin in the intestines. Nitrite, which indicates bacterial activity, and leukocyte esterase, which is white blood cell activity. All right, so in good old fashion, we got to break down each one of them, right? So glucose, we're checking sugar, right? And so if you have patients with high glucose levels, they probably got some type of diabetes, they got something like that going on. A lot of times on pediatric urine specimens, you'll see you're looking for galactose, fructose, pentose, and lactose. And that CLIN test you see on the bottom is usually the reflex test that we use if there's something that showed up positive on the glucose results. Okay. So the significance of a positive urine glucose is detectable amounts of glucose in urine, right? And occurs when the blood glucose exceeds the renal tubal reabsorption capacity. All right. So this is another really good slide, because you all are gonna be asked to determine the difference between that hyperglycemic associated and that renal associated glucose result, okay? So hyperglycemic associated, you are found in diabetes mellitus, Cushing's syndrome, acromegaly, and gestational diabetes. Renal associated are associated with Fanconi syndrome and advanced renal disease. Okay? And we'll break it down a little bit more. Okay, hold on. Before we move on to the next slide, I want to make sure that you all are getting this. So hyperglycemic associated is associated with what? That first one? Diabetes, and then this next one, renal associated, was that first one there, that first condition? Fanconi, okay. Bilirubin conjugated, this is from waste products from hemoglobin, breakdown of the liver. It's supposed to be negative, and if it's not, we'll report it as small, moderate, or large. So we've seen this slide before, and you see that little money with the wings, so you know that this is important. So on that last block, we had focused more on this top portion about the red blood cell life cycle, right? So now for this block, we're going to be focusing more on this bottom half, right? Once that red blood cell is broken down, and then how it's broken down to become waste, okay? So once, So once the RBC dies, right, and it's broken up, it goes from eaten by that macrophage that is broken up into iron, and then the iron, it goes on a transferrin, right, goes into the liver, becomes ferritin, goes back out, and goes back into the bone marrow. But then you have a portion of that iron where the bilirubin is broken down. That bilirubin is then taken down into the small intestine, down into the large intestine. From there, it becomes urobilinogen, which goes into the kidney, becomes urine, and then the other half of that urobilinogen becomes stercobilin, which becomes feces, okay? So we're just gonna be focusing more on that unconjugated portion and unconjugated portion of the RBC breakdown and bilirubin metabolism. All right, so what's the significance of bilirubinuria? Okay, we have prehepatic, hepatic, and posthepatic. All right, prehepatic, you have hemolytic jaundice, which is an increase in hemolysis. This raises that unconjugated or direct bilirubin levels in the blood. You have hepatic, which is mechanism is hepatocellular jaundice. The liver damages reduce bilirubin and increase unconjugated indirect bilirubin in the blood. And then last you have posthepatic. The mechanism there is obstructive jaundice. You have a blockage in the bile ducts. This prevents the bilirubin from reaching the intestines and causing an elevated conjugated direct bilirubin in the blood. Okay? So when we look at prehepatic, common causes are sickle cell disease, hereditary spherocytosis, autoimmune hemolytic anemia, thalassemias, and pernicious anemia. Hepatic, I want y'all to know viral hepatitis, alcohol, liver disease, and for the post-traumatic, gallstones, tumors, and strictures. All right, ketones. Ketones cause from excess of fat metabolism in the blood. It's supposed to be normal, but if it's not, we will report as trace, small, moderate, or large. So anytime we see any type of positive ketone result, you want to think of either prolonged fasting, starvation, or somebody might be on that ketosis diet. And you'll see that a lot in alcoholism as well. All right, we have specific gravity. Your normal values are going to be between 1.005 to 1.030. All right, 1.002 to 1.040 usually indicates a healthy kidney. And it also can be done on a refractometer. You all will not be doing that, but in the lab we will run specific gravities on refractometers if needed. All right, so what is the significance of an abnormal specific gravity result? This is very important because we're going to be talking about diabetes, so you all got to really know that, right? So we have low, less than 1.005, hypostenuric. You will see that in diabetes insipidus. Anything that's high, of high specific gravity, you'll see that in dehydration, kidney disorders, okay? So what is that term for low specific gravity results? That's highlighted there. Hypostenuric, and that's common, and a common cause is what? Diabetes insipidus, good. All right, osmolality, all right? Osmolality is when there is a measures the number of particles in a fluid sample. All right, high blood and plasma. Okay, so osmolality is really your portion of urine to blood and what the products that are in urine to blood. Okay, and we'll talk more about it on this next slide. It breaks it down a little bit better. So we're looking at the ratio of urine to serum plasma osmolality. Okay, in a normal values for urine, osmolality is 300 to 900 millimoles per kilogram. In a 24-hour urine, it's 500 to 800, and in serum plasma, 275 to 295. All right, so this chart is important. That's why there's a lot of highlights on there, okay? Just like you all should be highlighting. All right, so normal, 1 to 1 to 3 to 1. If you see a 1 to 1 to 3 to 1, which means the urine to serum osmolality ratio, that is considered a healthy hydration and kidney function. If you see a 3 to 1 where the urine concentration is higher than the blood and plasma, this will indicate dehydration, excessive sweating, vomiting, or diarrhea. And then lastly, if you see the urine concentration that's lower than the blood or plasma concentration, you're thinking neurogenic diabetes insipidus or nephrogenic diabetes insipidus, okay? Important slide. Now we're gonna break down the difference between neurogenic and nephrogenic, okay? So to differentiate between the two, we will run what's called a Miller-Moses test. And during a Miller-Moses test, you will have your patient in your room, you will do a controlled fluid intake, we provide them some fluid and then inject them with ADH, okay? And during that time, if the ratio increases, where the urine increases to the serum, then you think neurogenic, all right? That means if the ratio improves after the ADH injections, the kidneys are working and it's the brain that's not producing ADH, okay? So neurogenic. If the ratio stays low after the procedure, the kidneys aren't responding even when ADH is present, and so that's nephrogenic. So there's something going on with the kidneys, okay? It's a very important slide, all right? As indicated by those little the dollar with the wings. All right, so let's move on to blood and hemoglobin. All right, so sources, kidney dysfunction, and the red blood cells are not filtered in the glomerulus. Your normal values are negative. Results can be negative, trace, small, moderate, or large. So here's some significance of positive urine and blood hemoglobin results. So you see hematuria on top. You see common, and what's that common term off to the right?
UTI.
UTIs, y'all. UTIs. So if I say anything about there's a bunch of white blood cells, there's a positive nitrite, there's greater than 3 red blood cells per high power field, your patient has pain, complaining of pain during urination, you're thinking what? Okay, y'all got it. Y'all got this whole block. Okay, so here are some lab findings, and this is just pretty much going on about, this is just talking about red blood cells versus hemoglobin versus myoglobin. Okay. So if you're seeing cloudy red is red blood cells, clear red, then hemoglobin, clear to red brown, thing is myoglobin in there. Oh, and I really like that clinical scenario too, okay? All right, chemical analysis of urine pH. This indicates acid base and helps us assess certain health conditions in urinary tract stone formation. Okay, so just know that your first morning samples are gonna be slightly acidic, while your random samples are gonna be between 4.8 and 8.0, which is really really the whole low to high, right? Okay, so the significance of urine pH testing. Urines that have more of an alkaline pH value, so anything that's greater or equal to 7, you're thinking what? What's that term again? UTIs, right? Renal tubular acidosis, all right? If you have urine with more acidic pH, which less than or equal to 6, you're looking at common causes like diabetic ketosis, high protein diet, and E. coli. Or UTIs can also be present, but it's E. coli specifically that's causing an UTI. And then also in a more acidic type of urine, you'll see more of those cystine stones. And we'll go a little bit more into stones into that second part of the urine lecture. All right, proteins. Normally there's supposed to be no proteins in blood, okay, and urine. Ooh, I just like to talk about blood, I don't know what's going on. But urine is what we're talking about. Okay, so key proteins in urine. So the albumin should not be in urine. If there's albumin, you'll think of kidney damage or diabetic neuropathy. TAM's horseful protein is also a very abundant protein in normal urine, and this inhibits bacterial adherence. Okay. So here's some quantitative methods of uroprotein. So once we do that dipstick, we see that there's protein in the urine, then that will reflex us, or we will then provide confirmation testing, and that is called, the confirmation testing for urine protein is sulfosylic acid, or that SSA, and that will just confirm that there's protein in the urine. Okay. All right, so this is protein urine based on the source, pre-renal, renal, and post-renal. Pre-renal associated with heart failure, renal, you'll see probably albumin in there, associated with glomerulonephritis and diabetic nephropathy. I don't know, I'm saying it wrong. Post-renal, TAM's horseful protein associated with what infection? Okay. All right, another great slide. Anything that's listed like this, you just know it's really good, and you know you got to study this, okay? So benign transient causes of proteinuria. Dehydration is one, okay? Exercise, fever, stress, medication, pregnancy, all of these can cause proteinuria. But the one that's really important is that orthostatic, right? Transient protein only when upright. So you want to collect this during first morning urine. It's a daytime urine, and this could be a diagnostic or pathologic proteinuria, okay? So orthostatic. It's really the only one on here that's, that would be considered pathologic. Urobilinogen, this is that colorless byproduct of bacterial action on conjugated bilirubin in the intestines. And of course, like we had talked about a couple of slides ago, this is small amounts are excreted in the urine, but mostly in the feces. This is what's giving the urine that yellow color, and this is converts to urobilin. Urobilin, right? This is in the presence of light and low pH. All right, so we don't need it on this slide. But this slide, yes, this slide I have to talk about. All right, so types of jaundice, we have prehepatic, hepatic, and post-hepatic, all right? So in prehepatic, a clinical example of prehepatic would be hemolysis, all right? The blood bilirubin will be increased, unconjugated would be increased. The blood conjugated would also be increased. Your urine bilirubin will be negative, and your urine urobilin will be increased. And you will see that in dark brown feces, okay? So hepatic, which is one that would be probably the most common that you all will see as PAs. You'll see that on those that have viral hepatitis. You'll see that increase in that unconjugated, decrease in the conjugated bilirubin, negative urine bilirubin, decreased urine urobilin in that tan colored feces, okay? So just make sure you know. All right, there's one question that was thrown in here. How does prolonged light exposure affect durability results in urine testing? Yeah. Causes a false negative due to light degradation. And there's the answers there. Okay. Nitrite, remember we said that's dealt with, that has to do with bacteria, and we will confirm that with a microscopic examination. And why is microscopic examinations important to you all? Because it's ppm, right? And what's ppm? Now, will you be looking at a microscope? Probably not, but you might, okay? All right, so nitrites, right? So these are the common urine organisms that reduce nitrate to nitrite. So you have E. coli, Klebsiella, Proteus mirabilis, Enterobacter species. Right? And sometimes there'll be false negatives, and why do you think that is? Remember I was saying, if you don't get it to us in time, it's sitting around, what do you think is happening to it? It's breaking down, right? That bacteria, yeah, and growing in there, right? And so sometimes we'll have that false negative. Okay? Leukocyte esterase, right? That's just the presence of white blood cells in the urinary tract. Dealing with what infection? UTIs. All right, so the significance, right? Often coming with UTIs. You have these non-bacterial infections, though, which are really important. Okay? The non-bacterial infections, right? You have vaginal or urethral infections. This includes trichomonas, yeast, chlamydia, mycoplasma, or viruses. And those can also cause a positive leukocyte esterase result as well. You can have GI inflammation. And the clinical significance is that this can be a high negative predictive value. Okay? So, UTI is associated with bacteria, and then the non-bacterial is what? What are some things that can be seen in there? Trichomonas, yeast, chlamydia, mycoplasma viruses. Good. What? ELOs.
Hello.
What? Questions? Okay, so we went through the first one. Y'all want to go through the second one, or do y'all need a break? I know it's Friday afternoon. I know you don't. I know. I don't know I asked y'all. I don't know I asked. Okay, let's go ahead and get to this. Number 2. Block 2. Okay, so this one, just a continuation of what we talked. This is only about 38 slides, and this is we're gonna go more into the microscopic portion. Okay. Okay, part 2. ELOs, actually condition standards are the same. Here are your ELOs, are more than welcome to read. And of course, this comes from chapter 29 of our reference. All right, so here's our clinical introduction scenario. A 40-year-old presents with pain, fever, and dysuria. The dipstick urinalysis shows positive leukocyte esterase, nitrite, and trace blood. A microscopic examination reveals white blood cell counts, moderate bacteria, and greater than 5 white blood cells per high power field. These findings confirm an upper urinary tract infection, prompting antibiotic therapy and further renal evaluation. All right, so microscopic examination. You all will see, I will have a lot of panels on this test, so just know the words. I will not necessarily put the pictures up for you all, okay? But I will make sure in my questions that it's very descriptive so you know what to select, okay? So here are some insoluble materials or form elements that you can see in microscopic examinations. So we have some pictures here of some bacteria. Look like we got some crystals in here and maybe some white blood cells going on. But these are some common ones. Crystals, bacteria, mucus, sperm, and just junk, artifacts. So things coming off of the air, sometimes powders are in there, even fibers from your clothes. Okay. So a microscopic examination is performed when there's anything abnormal on that dipstick. Okay. All right, so let's talk about the cells that can be found under the microscope. So red blood cells is reported as what is highlighted? Reported as?
Allouria.
Very good. All right, so normal is 0 to 2 cells per high power field. If it's greater than that, then something else is going on with your patient, okay? UTIs on there again, okay? Woo, UTIs. All right, so white blood cells, they're reported as
Allouria.
pyuria, okay? Normal range is 0 to 5 cells per high power field. If you see anything greater than that, then we are looking at some type of infection, UTIs, kidney bladder infections, interstitial nephritis, or STIs. Squamous epithelial cells, these are those cells that are found in your lower urinary tract, right? Your vaginal or urethra. Now, squamous epithelial cells does not necessarily mean there's something going on, right? It could just be somebody submitted urine without wiping properly, right? Without doing that clean catch like we need to. So if you see anything that's greater than 10 squamous epithelial cells per high power field, what we doing? Rejecting it. We're saying, get it out of here. We're not running it, right? And the reason why we're not running it, because we cannot get any culture for bacteria. We can't do any sensitivity, some antibiotic sensitivity testing, all right? So make sure you let your patients know that. Clean catch. All right, transitional epithelial cells, these are found in the bladder, ureters, and the renal pelvis, okay? So you normally, when we see these, if you see them in clumps like this, that shouldn't alert you for anything. That's actually kind of normal. It's when there's large clumps all over that slide, then you start thinking something else. Either it came from a catheter, it could indicate some type of infection, kidney stones. In some cases, it could be cancer. But of course, you would have to run some additional testing to confirm that. All right, we have renal tubular epithelial cells. These are the ones that line the renal tubes. Okay, 1 to 3 in a high power field is usually normal. Anything greater than 3 is going to suggest kidney injury or damage or dysfunction. So how many suggest kidney injury or damage to or dysfunction? More than 3. And also with renal tubular epithelial cells, sometimes there'll be oval fat bodies in there. That's also seen in nephrotic syndrome. Okay. Okay, so this is just pretty much talking about what I just said, but it's just in a nice chart if you all like charts. Okay. So just know squamous epithelial cells are normal. Okay. Anything greater than 10 indicates contamination. Transitional epithelial cells are also normal, but if you see large sheets of them, we're thinking inflammation or cancers. And then renal tubular cells, think a whole bunch in there greater than 3. We're thinking nephrotic syndrome. Okay. So these are our casts, and so this is just pretty much showing where these casts are formed. All right, so casts in the urine are those cylindrical structures formed precipitate exclusively in the kidney tubules, all right? And they're composed of protein cells and debris, and they mold into this weird shape, and they show up on the microscopic pyramids, okay? Okay, so here's the classification of casts. You have your matrix, which is your hyaline cast or wax cast, which we talked about in block 1, so we're not going to talk about it again. Then we have cells. You have your red blood cell cast, your white blood cell cast, you have renal tubular epithelial cell cast, and then you have a mix of all of them. And then the pigments can come from the hemoglobin, myoglobin, bilirubin, or from drugs. Okay, so this is a new cast. You've seen this picture before. I know y'all seen this picture before. Yeah. We really like to talk about this in the PA program, but okay. So we have hyaline, right? Transparent, smooth, and this is the most common cast, all right? And this is non-pathologic. Then you have your waxy, which we talked about in our last block. Okay? So hyaline is common and it's also what? Non-pathogenic. Okay, good. Now got it. All right, cellular cast. You have red blood cell, white blood cell, and you have your tubular epithelial cell cast, major cast. Okay. Red blood cells associated with nephrotic syndrome, white blood cell, kidney inflammation or infection, and then we have RTEs, which is your acute tubular necrosis. Right? Very important slide here. All right, and this is also really important. So granular casts, right? These inclusion casts, these are coarse or finely granular textures, and they are found in the renal, they may have renal tubular damage. You have fatty casts that can be associated with nephrotic syndrome or significant in lipiduria. And then broad casts you'll see in the end-stage renal disease. These tend to be wider and they're larger. They have blunt or broken ends. So if you have a female, she has back pain, she has dark yellow urine, and the renal tubular cells are greater than 3 per high power field. What are you all thinking? Yeah. This time it's not UTI. Okay, good. Yeah, you're thinking some type of renal tubular damage. Okay, good. All right, so crystals. All right, so like I said, from precipitation of urine salts, and these are due to changes in pH or concentration. And most crystals have like limited clinical significance. Okay. Some can be fatal, some are pathological, some aren't. Okay. So those pathologic crystals, they're highlighted for a reason. Okay. Which means we need to highlight them for a reason, right? Okay. So commonly formed acidic urine, you see crystal uric acid and calcium oxalate. I think we did this last block, didn't we? Yeah, so we can move on to the next slide. We're not done. I'm not gonna beat you over the head. We're just gonna talk a little bit more about some that we didn't talk about last one, okay? So you have acidic urine, that calcium oxalate, this is the most common crystal that you'll see. If it's greater than 4 to 5 high power field, think kidney stones, okay? Calcium phosphate, you'll see in renal tubular acidosis, and ammonium burate, you'll see in what infection? UTIs. And here are some more important crystals. Okay, so here are some other insoluble materials that can be found in urine. We talked about bacteria, how associated with UTIs, and those symptoms will include dysuria, so that burning in urination, frequent urination, cloudy urine, and bloody urine. Okay, and please make sure to submit a fresh urine sample. Don't send us no old urine. All right. Yeast in urine. I think we talked about this. Yeah, we did talk about this in block 1, but we talked about it more in the blood. But yeast can be found in urine as well, and sometimes seen in those patients that are using antibiotics or if they're immunocompromised. Okay. Sometimes they can be mistaken for red blood cells, but yeast have more of a budding look than red blood cells. Parasites can also be found in urine. Okay, so we have trichomonas, which is that sexually transmitted infection, and they're identified with this. They got that round. They got this like flagella, and a lot of times if it gets us in time, we'll see them while they're still mobile. They'll have like they got a weird jittery movement, okay, jitterbug as they call it here. And then we talked about the vermicularis. Where did we was that most commonly found in? The children, right? And how are you collect those? Yeah, put that tape on there. Yep. Okay. Mucus in urine. So this is not necessarily, this doesn't always necessarily indicate that there's something going on. A lot of times you'll see this in women, that'll be contamination from the vaginal canal. But it could indicate some type of irritation or inflammation, okay? So a lot of times we'll see mucus also involved with UTIs as well. And It's commonly caused by that protein material from glands and epithelial cells, okay? And this is important, so just make sure you know that mucus is not necessarily pathologic, but if it's associated with bacteria and white blood cells, then you know something's going on with your patient, okay? All right, we're almost there, we're in the last stretch. All right, sperm in the urine. It's seen in both men and women. The only time it's really so it's commonly caused. It also indicates recent sexual activity. It may indicate a problem with the bladder sphincter or retrograde ejaculation. So that means that the semen will enter the bladder instead of the urethra during an orgasm, okay? So this may not be harmful, but it may indicate or a cause of male infertility. So it is important that when sperm is found in the urine and it's still mobile, we'll know that the sperm is good to go, okay? So sperm can be undetectable after 5 hours, and large amounts may cause a positive protein test on the chem strip. So if we do see a positive and we see the sperm in there, then we know it's probably sperm that's causing that positive protein and not necessarily like a proteinuria or something else going on with that patient. Okay, so starches, not really clinically significant, just like our starches can be, it's just contamination. So that's just powders, you know, that comes off of the stuff that you put on your skin and can come off your clothes. Okay. All right, and these are just panels. I'm not gonna go through each one, but just make sure you're looking at panels because this is how it's gonna be presented to you on the test, all right? So just like I kept indicating about UTIs, make sure you're looking at these, looking at what results show up in a lower UTI, upper UTI, that non-bacterial infection, that one's important, okay? And let's see, nephrotic syndrome, that one's important. Rhabdomyolysis, dehydration, okay? So make sure you all are looking at these, okay? So you know what to select, all right? So there's like 3 slides of these that I would like you to look at. Got any? No? Okay. Hey, y'all enjoy your weekend, but if you have questions, please